Are you wondering if mupirocin usage in your hospital is similar to other hospitals in Australia? There are very few clinical indications requiring the use of topical antibiotics, and the therapeutic guidelines warns against prolonged or widespread use of mupirocin due to the high risk of high-level resistance in MRSA. The main clinical use of mupirocin in hospital inpatients is decolonisation of patients colonised with Staph aureus prior to surgery or in the ICU setting. In the outpatient setting, which is not within the scope of this poster, it is used in dialysis patients nasally or topically to prevent exit site infections or peritonitis. Mupirocin is a topical bacteriostatic antibiotic that's been available in Australia since 1991. Strains of mupirocin-resistant Staph aureus started emerging soon after it was introduced into clinical practice. In 2018, 1.9% of MRSA isolates across Australia were reported to have high-level resistance to mupirocin, with some states reporting rates of up to 5%. In January 2019, the National Antimicrobial Utilisation Surveillance Program, or NAUSP, began collecting data on the use of topical antimicrobials in Australian hospitals. Of the more than 200 hospitals registered with NAUSP in 2019, 113 provided pharmacy dispensing data on topical antimicrobial use. To compare the total usage rates of mupirocin between hospitals in 2019, the number of milligrams of active ingredient per 1,000 occupied bed days was calculated, which was derived from pharmacy dispensing records and patient activity data. Discharge and outpatient usage was not included. The interesting finding from the calculated rates was the variability between hospitals. The median annual inpatient usage rate in 2019 was relatively low at 89.3 milligrams of mupirocin per 1,000 OBDs. The majority of hospitals had total annual usage rates of below 1,000 milligrams per 1,000 bed days, or equivalent to 17 tubes of ointment per 1,000 bed days. However, 10% of hospitals had very high usage rates. These high usage hospitals were a mixture of private and public hospitals and range from large principal referral sites down to very small peer group C and D hospitals. The highest annual reported usage was over 13,000 milligrams per 1,000 OBDs. This equates to slightly more than 1 3-gram tube for every 5 overnight bed days. Of the 113 hospitals that contributed data on topical antimicrobial use, 62 were able to differentiate ICU usage from non-ICU use. In the ICU setting, the variability in usage was even more extreme. Almost half the hospitals providing ICU data on topical antimicrobials reported no mupirocin usage at all. The median annual use in ICU was 12 milligrams per 1,000 bed days. However, the average ICU usage was 1,644 milligrams per 1,000 OBDs. The average usage rate was heavily skewed by some hospitals with extremely high usage. The graph here, which was shown using a logarithmic scale, shows the variability in ICU usage in Australian hospitals. The highest reported ICU usage rate was over 65,000 milligrams per 1,000 OBDs. This equates to 1 3-gram tube of ointment per patient per day. Finally, we looked at the monthly inpatient usage by state. Again, there's wide variability across Australia at a statewide level, with some states recording much higher usage rates of mupirocin per bed day than other states. These results illustrate the wide variability in clinical practice regarding the use of mupirocin, both in the total hospital inpatient setting as well as within the intensive care setting, which is likely driven by varying decolonisation protocols. The evidence for the use of mupirocin for Staph aureus decolonisation is variable dependent upon the setting or the type of hospital treatment or intervention. Further research into the relative rates of Staph aureus bacteremia between ICUs comparative to their mupirocin usage would provide further evidence to standardise the recommended use in this setting.